Hi, my name is Walter Chan. I'm the director of Center for Gastrointestinal Motility at Brigham and Women's Hospital. And today I'm going to be talking about COVID in the GI tract. We're going to start with talking a little bit about the COVID-19 pandemic, including the epidemiology, pathophysiology, and symptoms. And I'm going to go into a little bit about the GI manifestations of COVID, as well as some potential involvement of other GI organ systems like pancreas, liver disease, and IBD. And then I'm going to finally talk a little bit about long COVID-19 GI symptoms that we might be seeing more and more as we come to the end of the pandemic. So a little bit about the timeline of COVID-19. Um, the first case of COVID-19 was described in December of 2019 in China. The pathogen of COVID-19, which is a SARS-CoV-2, was identified by the World Health Organization in January 2020, with the first death reported in China linked to COVID-19 in the same month, as well as the first case being reported outside of China around that time. Finally, this was declared a pandemic in March of 2020. SARS-CoV-2 is coronavirus. It's a positive sense single-stranded RNA. It's a type of beta coronavirus, which is similar to MERS-CoV and the previous SARS-CoV. It is suspected to have a zoonotic source. The incubation period is for SARS-CoV-2 generally has a median of 4 to 5 days, and typically within 14 days. It is known to have a person-to-person spread, mainly through respiratory droplets. The pathophysiology of SARS-CoV-2 usually starts with the binding of the virus to the ACE2 receptors via the spike proteins. This allows viral entry into the cells. This process is similar to the replication entry for SARS-CoV and MERS-CoV. This is followed by the binding of SARS-CoV to the ACE2 receptor may induce direct cytotoxic effect. It may also lead to a dysregulation of the renin-angiotensin system, leading to tissue injury, remodeling, inflammation, and changes in vascular permeability. It can also lead to endothelial cell damage, resulting in thromboinflammation, as well as a dysregulation of the overall immune response to the SARS-CoV-2 virus. This is overall a multi-system disease, given the potential pathophysiology that was identified. And specifically in the GI tract, symptoms associated with SARS-CoV-2 included diarrhea, nausea, vomiting, abdominal pain, and anorexia. Given the important role of the ACE2 receptor for viral entry of SARS-CoV-2, the expression of ACE2 in the GI tract becomes important. ACE2 receptors can be found throughout the GI tract, with the highest concentration in the small bowel, followed by the colon, gallbladder, liver, esophagus, and the pancreas as well. So you can see it's present pretty diffusely throughout the GI tract. Interestingly, the amount of ACE2 receptors in the lungs is actually lower than in a majority of the GI tract. So the transmission of SARS-CoV-2 may occur even outside of the respiratory tract, and the GI tract may actually play an important role. There have been some study looking at the actual ACE2 receptor expression on the GI tract. This is a study looking at staining of the ACE2 receptor expression using tissue samples throughout the GI tract. As you can see here, ACE2 receptors are abundantly expressed in the glandular cells of gastric, duodenal, and rectal epithelia. It is rarely seen in the squamous epithelial cells of the esophagus. Specifically, in the enterocytes, there have been studies that have found both both the SARS-CoV-2 antigen and viral particles that are present in small biopsies from COVID-19 patients. Interestingly, in most cases, the amount of inflammation is mild or absent, and the amount of viral antigen and particles did not correlate with patient GI symptoms or COVID-19 severity. The presence of these viral antigen and particles were more common if the samples were taken closer to the diagnosis of COVID-19. And the viral antigen may be detectable up to 7 months after symptom resolution of these patients. So thinking back to the diagram we previously looked at, what we can see is that the pathophysiology of COVID-19 is truly multifactorial. We know that direct virus-mediated tissue damage is thought to play a large part in the lumen of the GI tract to cause symptoms of nausea, vomiting, and diarrhea. And the inflammatory-mediated damage is believed to be the main driver of liver injury. It is also important to point out that endothelial inflammation may also result in microvascular small bowel injury, which has previously been described. And additionally, SARS-CoV-2 may result in alteration of the intestinal flora by the virus, which may contribute to GI symptoms and severe disease progression. So what are some, how do the GI tract symptoms play into the overall recognition and diagnosis of SARS-CoV-2? If you think back to the early days of the pandemic, GI symptoms were not really described as part of the symptom complex as COVID-19. And this is a list of symptoms that were from the CDC website back in May 2020. However, some early reports, even from China, have suggested that GI symptoms might be present in patients with COVID-19. In a study of over 1,000 patients with lab-confirmed COVID-19, diarrhea was reported in about 3.8% of patients. Another study looking at a total of 204 patients from 3 hospitals in China from the early days of the pandemic, the majority of them reported fever with and without respiratory manifestations. Interestingly, in this report, 50% of patients reported some digestive complaints, including the most commonly anorexia, also diarrhea, vomiting, and abdominal pain. In total, about 18.6% of patients reported some type of GI symptoms, excluding the anorexia. So this tells us that GI symptoms may be common among COVID-19 patients. And even in the first COVID-19 case in the US that was confirmed, this particular patient presented with cough, nausea, and vomiting. And he also developed diarrhea on day 6 of symptom onset. So even from the first case on in the US, GI tract symptoms was prominent. And there have been some early studies looking at this. This is a study actually that was performed here at Brigham, which is a multi-center study of hospitalized patients with SARS-CoV-2 infection. A total of 318 patients were included from this early on in the pandemic. In total, 61.3% of these patients reported at least one GI symptoms, with the most common one, again, being anorexia, closely followed by diarrhea, as well as nausea. Interestingly, GI symptoms were the only complaint in about 8.9% of patients, and it's a predominant symptom presentation in about 11% of the patients. And in about 15% of the patients, GI symptoms were the initial manifestations of the COVID-19. In the same study, we also found that GI symptoms were associated with other symptoms of SARS-CoV-2 at the time of presentation, including fatigue and myalgia. And 2 of the symptoms that are commonly associated with COVID-19, including anosmia and ageusia, both correlated with symptoms of nausea and anorexia. Interestingly, there were no significant difference between patients with GI symptoms and those without GI symptoms in terms of their baseline characteristics, lab data, and clinical course and outcome. So it does not appear, at least from some of these from our study, that patients with GI symptoms did worse than those without GI symptoms. Another large early study in the US came from Weill Cornell in New York, where they found that 33% of patients had at least one GI manifestations, with the most common one being diarrhea, followed by nausea, vomiting, and abdominal pain. They did find that GI symptoms were associated with a higher rate of hospital admission, but they note that patients with GI symptoms also had lower mortality and decreased ICU admission and death. Later on, a meta-analysis was performed of 47 studies, specifically looking at GI symptoms in COVID-19. This meta-analysis included over 10,000 patients. It was found that GI manifestation associated with COVID-19 was found in less than 10% of patients on pooled data, with the most common being nausea and vomiting, followed by diarrhea, abdominal pain, and elevated liver enzymes. However, interestingly, if you look closer at the data, the prevalence of GI symptoms appeared to be higher among studies that were outside the US. As you can see here, for studies from countries other than China, the prevalence of nausea, vomiting, and diarrhea ranged from about 15 to 18%, whereas for those studies in China, they're around 5%. It is possible that this is due to some reporting biases, specifically in a lot of the studies from China from very early on in the pandemic. At the time, GI symptoms were not recognized as part of the symptom complex. It is possible that those were not either reported or recorded early on, resulting in certain reporting biases. But given all these data supporting the importance and the important role of GI symptoms in patients with COVID-19, an updated CTC guideline later included nausea, vomiting, and diarrhea as part of the symptom complex of COVID-19 infections. What about involvement of COVID-19 in other GI tract organs? There's some study looking at pancreatic involvement. Given that there are ACE2 expression in the pancreatic islets, there were concerns regarding pancreatic injury from COVID-19. Indeed, previously in 2003, SARS-CoV was detected also in the pancreas. And there was an early report from China that described evidence of pancreatic injury in up to 17% of active COVID-19 cases. This study included a total of 52 patients. Although the pancreatic injury was defined as any abnormal or elevation in amylase or lipase. However, we know that elevation in pancreatic enzymes alone may not represent pancreatic injury or involvement. Later on, we performed a retrospective analysis of 6 hospitals within our system that included 71 COVID-19 patients with measured serum lipase levels. In total, 12% of the patient cohort developed elevated lipase levels, with only 2 or 2.8% they're at level greater than 3 times upper limit of normal. Importantly, no patient in the cohort developed acute pancreatitis per clinical criteria. So what we found was that hyperlipemia appears to be uncommon and do not appear to be associated with worse outcomes. There's later another study from Italy looking at over 250 hospitalized COVID-19 patients in Rome. And what they found was that about 12% of them had mild pancreatic enzyme elevation. But only, again, a small percentage of them, about 4% of them, had elevation in their pancreatic enzymes that are greater than 3 times upper limit of normal. And overall, out of this 254 patients, only 2 met diagnostic criteria for acute pancreatitis. On a adjustment analysis, mild and severe pancreatic enzyme elevations were associated with ICU admissions for these patients. And other international multi-center studies of over 1,700 patients with acute pancreatitis, 149 or 8.3% of them had concomitant SARS-CoV-2 infection. On a just-in analysis, acute pancreatitis with SARS-CoV-2 infection do appear to have a worse hospital course and clinical outcome. They all had increased length of stay, persistent organ failure, and higher rate of 30-day mortality. What about liver injury? We know that ACE2 is expressed in hepatocytes and biliary epithelial cells. And liver injury has been reported in patients with SARS-CoV-2, and they're primarily hepatocellular in origin. The severity of the overall disease, SARS-CoV-2 infection, may impact the degree of liver injury. Although the majority of liver enzyme elevations that have been seen in these patients are mild. It was thought that the hepatic injury were possibly immune-mediated and not necessarily related to direct viral cytopathic effect. And AST and ALT abnormalities were reported in about 20% of patients. In a very early study of 60 hospitalized patients with COVID-19, approximately 69% of them had at least one abnormal liver biochemistry on admission. 93% of these patients ultimately develop elevations during their hospital course of liver enzyme. 17% develop aminotransferases greater than 5 times upper limit of normal. And notably, both the admission and the peak liver enzymes were higher among patients requiring mechanical ventilation. Given many of the patients that developed severe COVID-19 disease were patients that were overweight or with metabolic syndrome, there was concern about whether or not medications that are used among these patients may affect liver enzyme abnormality or liver injury. Indeed, statin use was common among this cohort of hospitalized patients with COVID-19. However, the use of statin did not appear to impact the liver enzyme levels among these patients. What about patients with non-alcoholic fatty liver disease or metabolic fatty liver disease? This has been looked at in a couple studies. One of them was performed by us, looking at 363 patients with COVID-19. We found that overall 19% of these patients had chronic liver disease, with about 15% of them meeting criteria for non-alcoholic or metabolic fatty liver disease. Overall, chronic liver disease and NAFLD were independently associated with ICU admission and mechanical ventilation. And the presence of cirrhosis was an independent predictor of mortality. In another study performed in China, NAFLD or MAFLD was associated with a higher degree of liver injury. Patients were 6 times more likely to progress to severe COVID-19 illness who also have underlying fatty liver disease. There were also reports that patients with fatty liver disease may also have a longer virus shedding period from studies coming out of China. There's another larger study encompassing 21 US institutions looking at COVID-19 in patients with chronic liver disease. Overall, the study found that the all-cause mortality associated with COVID-19 in this population is about 14%. Some of the risk factors for higher mortality included alcohol-related liver disease, patients with decompensated cirrhosis, or hepatocellular carcinoma. What about liver transplant patients? In the multi-center study of over 100 liver transplant recipients with COVID-19, the mortality rate was found to be about 22%, with an ICU admission rate of about 26%. Evidence of liver injury in these patients were associated with higher mortality and ICU admission. And reducing immunosuppression regimen did not appear to increase mortality or the risk of graft failure in this population. What about IBD patients with COVID-19? This is a population-based retrospective cohort study that included over 190,000 patients with COVID-19. Overall, 232 of them had IBD, with roughly equal proportion of Crohn's and ulcerative colitis patients. This study found that GI symptoms were more common among patients with IBD, but only 27% of the IBD patients that was found in this cohort were on immune-mediated therapy. Within this population, there was no significant difference in severity of COVID-19 between IBD and the non-IBD group. In another cohort study of over 5,000 patients at our system, 39 of them developed COVID-19. It was noted that the rate of COVID-19 was similar between patients treated with immunosuppression and those who were not. The use of immunosuppression was also not associated with more severe COVID-19 infection. Data from the secure IBD registry that included over 6,000 IBD patients with COVID-19 found that systemic steroid use was associated with an increased odds of severe COVID-19 hospitalization and death. Other commonly used IBD medications, including biologics, were not associated with severe COVID-19. What about vaccination for COVID-19 in this population, given that it is not uncommon for IBD patients to be on immune-suppressing agents? In a cohort study of IBD patients receiving COVID-19 vaccinations who were treated with infliximab versus vedolizumab, it was found that the serum anti-SARS-CoV-2 spike antibody concentrations that were induced by the vaccination were lower among patients treated with infliximab than vedolizumab. The seroconversion rates was also higher among patients with prior infection. It seems that vaccination after prior infection or second dose of vaccination led to seroconversion in most patients who did not seroconvert initially. Now let's talk a little bit about the long-term symptoms associated with COVID-19 infection. In a study from Italy, 164 COVID-19 patients and 183 controls completed questionnaire about 5 months after the COVID-19 infection. Persistent abdominal pain, diarrhea, and chronic fatigue were reported in over 30% of patients who recovered from COVID-19. When compared to controls, the frequency and severity of GI symptoms, anxiety, and depression were all greater among the COVID-19 patients compared to controls. In another study of 147 hospitalized COVID-19 patients from New York, during their follow-up with a median of 106 days, 16% of them reported persistent GI symptoms. Notably, this prevalence was higher than the prevalence of post-infectious IBS gastroenteritis, which is historically been reported to be about 10%. The risk factors for development of persistent GI symptoms after COVID-19 infection during follow-up included experiencing GI symptoms at presentation for the COVID-19 infection, as well as a history of depression. In another study, there was an online survey of 285 patients with a history of COVID-19. 40% of them reported abdominal pain with bowel disturbances. These include diarrhea, abdominal pain, constipation, and nausea. 35% of patients were taking new medications for new GI symptoms that were developed after the COVID-19 diagnosis. And the risk factors for having these persistent or newly developed GI symptoms included experiencing GI tract symptoms at presentation, having received antibiotics, and also hydroxychloroquine. Within this cohort of patients, 134 of them completed surveys with at least 6 months of follow-up time after the COVID-19 infection. And overall, there was an increase in prevalence of IBS symptoms, with 16% of them reporting IBS symptoms pre-COVID, up to 41% of them post-COVID. And this overall severity of IBS also increased, with an increase in IBS SSS score from 61 to a mean of 248 after COVID-19 infection. And new IBS symptoms were reported in 39% of patients with at least 6-month follow-up. Of course, there's limitation to this analysis, as there could be selection bias upon online survey respondents. However, it does appear that patients who had COVID-19, some of them develop new onset GI symptoms or worsen of their underlying GI symptoms afterwards. There's another study, there was a survey study of a larger population of 749 patients who recovered from COVID-19 with at least 6 months of follow-up. In this larger cohort, 29% of them reported GI symptoms self-perceived to be related to the COVID-19 infection. The symptoms included diarrhea, constipation, abdominal pain, nausea, vomiting, and heartburn. Overall, 11% of them reported GI symptoms as the most bothersome current symptoms after recovery from the COVID-19. So it appears that GI tract symptoms may be an important potential long-term symptoms related to COVID-19. So what are some of the risk factors associated with post-COVID-19 GI tract symptoms? This include experiencing GI symptoms during their acute infection, patients that have a history of mental health symptoms, either pre and or post COVID-19, the need for acute hospitalization during their acute illnesses, patients who experience loss of smell and taste during their initial presentation, and there have been some study looking at metabolome. It was found that a decrease in gut microbiome, tryptophan metabolism, and serotonergic signaling could be associated with post-COVID-19 GI tract symptoms. Now that we know GI tract symptoms are important, what about the impact of COVID-19 on patients with underlying disorders of gut-brain interaction and motility disorders? The studies have reported an increase in symptoms, medication use, and healthcare utilizations in patients with functional GI disorders and motility disorders after the start of the COVID-19 pandemic. And there appears to be important psychological impact from the COVID-19 pandemic, which may also affect GI tract symptoms. In a survey of IPS patients with comorbid anxiety and or depression, 92% of them reported increase in stress during the COVID-19 pandemic, 81% with increased anxiety. 67% of them noted increase in depressive symptoms. Among this cohort of patients, their IBS symptoms worsened in about 50% of them, with most common symptoms being abdominal pain, diarrhea, and constipation. In another survey study of over 2,700 patients with and without IBS, IBS patients reported worse emotional, social, and psychological well-being compared to non-IBS patients during the pandemic. Overall, the worsening of underlying IBS symptoms appear to be associated with a decreased willingness to continue social distancing measures. So it seems like the pandemic itself had a psychological impact that may affect a lot of patients with underlying disorders of gut-brain interactions like IBS patients. Another population survey of over 5,000 patients in Japan that was published, they compared patients with no underlying IBS functional dyspepsia to those with IBS with functional dyspepsia, or those with IBS and functional dyspepsia overlap. Overall, 11.9% of patients reported an increase in GI symptoms after the COVID-19 infection. And GI and psychological symptoms appear to be most severe among those with an overlap of IBS and functional dyspepsia, and were the lowest amount of patients with no history of IBS or functional dyspepsia. Risk factors for increase in GI symptoms in this cohort include those with IBS and functional dyspepsia overlap, patients with underlying psychological disorders, and patients who have stress at work or at school. Those who have a lower prevalence of GI symptoms are patients who are at a younger age, patients who take public transport commute, and those who either work or study from home. The diet may also impact GI tract symptoms and also be impacted by the COVID-19 pandemic. There are reports showing that there are changes among most patients' dietary habits and behaviors during the COVID-19 confinement. In a survey of over 2,700 participants in Colombia, overall, there's an overall unhealthier dietary pattern during the COVID-19 pandemic. This includes an increase in frequency of snacking and adoption of a more westernized diet, which typically includes more processed food. And there's also some reported increase in simple sugar and carbohydrate intake, which may be correlated with underlying GI tract symptoms. There may also be other lifestyle impact as well. In a survey of over 670 patients, development of new onset constipation was found in about 25% of them during the COVID-19 lockdown. Symptoms reported include a decrease in daily bowel movement and changes in stool consistency. Notably, this population of patients with new onset or newly reported constipations were more likely to have stopped exercising during the pandemic. Some of the risk factors for development of new onset constipation included female patients, patients with less water intake, and patients with a decrease in physical activity. Now, if we were to look at the overall prevalence and incidence of functional dyspepsia and IBS after COVID-19, there have been some meta-analyses that were performed. Overall, the pooled incidence of functional dyspepsia after COVID-19 was about 4%, and for IBS is about 12%. There appeared to be an increase in risk of functional dyspepsia and IBS development among post-COVID-19 patients compared to controls who do not have COVID-19 infection, with an odds ratio of about 8.07 in the functional dyspepsia group and an odds ratio of 12 in the IBS group. And we know that a lot of the symptoms that occur after COVID is an underlying autoimmune dysfunction that may be related to multiple organ systems, including the GI tract. Even in patients with COVID, we're seeing more and more patients who develop autonomic dysfunction related GI symptoms or disorder of gut-brain interaction or motility disorders. So what are some of the causes of post-COVID-19 chronic GI symptoms? There could be a number of different reasons why patients may develop chronic GI symptoms after COVID-19 infection. This could be related to increase in psychological stress or dietary changes that can lead to an increase of development of chronic GI symptoms or symptoms related to disorders of gut-brain interaction. Other potential contributors include the altered taste and smell perception associated with COVID-19 infection, perhaps central desensitization or central sensitization, underlying autonomic dysfunction that might be related to the COVID-19 infection, risk or hypersensitivity, metabolic dysfunction or diabetes, altered motility, or changes in gut microbiota that might be associated with COVID-19 infection. Having said that, how do we manage these long COVID-19 symptoms? Well, the management is actually very similar to often what we encounter with patients with other disorder of gut-brain interactions, such as IBS, especially those with post-infectious disorders. And this may include providing a positive diagnosis among patients who have suggestive symptoms and limit diagnostic workup unless there are alarming symptoms that are present. Reassure patient, explain that symptoms may improve or resolve over time as consistent with what we often see with patients with post-infectious disorders of gut-brain interaction. Lifestyle modification might help, such as having adequate sleep or exercising, making different types of dietary modifications that we often do for patients with IBS. Neuromodulation may play an important part, including the use of tricyclic antidepressants and other agents. Psychological therapy may be useful, just like we see in patient disorders of gut-brain interaction. This may include cognitive behavioral therapy or gut-directed hypnotherapy. Symptom-based pharmacotherapy likely play a big part, as we often use these agents to treat patients with underlying IBS. So for depending on whether they have diarrhea predominant disease or constipation predominant disease, agents can be chosen to target various types of symptoms reported by the patients. Microbiota modulation may or may not help, such as probiotic therapy. There's currently no convincing data that the use of probiotic will be useful for managing long COVID-19 GI tract symptoms. This is very similar to what we see in patients with IBS and other DGBIs. Finally, modulation of intestinal permeability may also help, similar to patient with post-infectious IBS, as it was thought that changes in intestinal permeability associated with the acute infection may predispose the patients to chronic GI symptoms or IBS. And there have been a very limited data and study on the use of the glutamine supplement as a treatment for altered intestinal permeability. So that might be considered as one of the treatment options as well. So in summary, we know that GI manifestations are prevalent among COVID-19 patients and may represent the predominant or initial presenting symptoms. COVID-19 patients with GI symptoms overall are not at higher risk for more severe outcomes, as we have seen, including death and ICU admission. The incidence of acute pancreatitis or pancreatic injury appears to be low. However, COVID-19 patients with acute pancreatitis are at risk for more severe outcomes. Admission and peak liver enzymes are higher among COVID-19 patients requiring mechanical ventilation. And chronic liver disease, fatty liver disease, and cirrhosis are all associated with more severe clinical outcomes, including mortality. We know that IBD and most IBI medications do not appear to increase the risk of COVID-19 and not necessarily associated with more severe COVID-19 outcomes. A significant proportion of COVID-19 patients may experience persistent GI symptoms after recovery. And new post-infectious IBS or worsening of baseline IBS symptoms have been reported after recovery from COVID-19 infection. An increase in active symptoms, symptom burden, medication use, and healthcare utilization among patients with disorders covering interaction increased during the COVID-19 pandemic. There also appears to be worsened stress, anxiety, and depression among patients during COVID-19 pandemic that may be associated with an increase in GI symptoms. Dietary and lifestyle changes during the COVID-19 lockdown, such as increasing carbohydrate ingestion, a reduction in water intake, and a decrease in physical activity may also play a role in GI symptoms associated with these patients. And the current management of post-COVID-19 GI symptoms are mainly based on the current treatment paradigm of IBS or other DGBI that may include lifestyle and dietary changes, use of neuromodulators, symptom-based management, psychological therapy, and perhaps the use of glutamine for intestinal permeability. Thank you.